Well, in Chapter 5, finally after getting anesthetized, we're all going to get high a little bit on morphine. And as we look at opioid analgesics, we're looking at a major tool to combat pain in patients, the use of opiates, and the constant juggling between the respiratory depressant effect of these drugs and their abuse liability. First, as an introduction, let's not forget that opiates work on receptors that are present simply because we do have endogenous peptides that are morphine-like. They belong to the families of endorphins, enkephalins, and dynorphins. Those three families of peptides actually bind to three receptor families, mu, kappa, and delta. Mu is the primary target of endorphins, and whereas dynorphins like to bind to kappa, the enkephalins like to bind to delta receptor. It is the mu pharmacology that we are most excited about. It's the one that is more important and the one for which morphine is the prototype. So in the mu pharmacology, what is special at the molecular level? Well, you should know that all receptors in this family of opiates are GI-coupled type of receptors. They are found pre- and postsynaptically and are not found in discrete pathways in our brain or in the periphery, but rather are found on interneurons. Interneurons having as a primary role that of modulating major pathways in our brain. Let's take a little page and I'm going to give you an idea of how it would work. Imagine you have here a big nerve terminal that releases a major neurotransmitter, maybe one such as norepinephrine, maybe one such as substance P, which mediates pain, in the dorsal horn of your spinal cord, maybe one that is never board tested that is called etc. Any of these famous neurotransmitters that you could think of tend to have somewhere some regulation on their synthesis and release. For that matter, you are now imagining a little neuron that actually can release an opiate, such as an endorphin, and this endorphin now binds to a mu receptor that is located presynaptically on the norepinephrine terminal. Well, the stimulation of a mu receptor will stimulate the GI coupling. GI coupling will lower cyclic AMP, decrease phosphorylation, and the net effect will be literally a decreased synthesis and release of any of the major neurotransmission. So imagine really an opiate neuron sits a little bit just like a GABA interneuron, a neuron that we find widely scattered in our brain that controls the activity of other pathways, and it does so negatively. I like the idea of the decreased norepinephrine between you and I. Remind me already, off the top of your head, what is an effect at the level of pupils? Don't we all know those famous pinpoint pupils that opiate addicts present with? Well, if you suppress norepinephrine release, you know as well as I do that parasympathetic becomes predominant and causes the severe constriction of pupils. So norepinephrine actually is a major target of opiate pharmacology, and suppression of norepinephrine will also come and help us understand some of the management of withdrawal later on. So let's not forget about it. As I go back to the PowerPoint presentation, we have some major points associated with the pharmacology of morphine. This is a drug that is used as a central analgesic, and it is used as such because it increases the tolerance to pain by suppressing the perception of pain, and therefore by causing your brain no longer to react to those nauseous stimuli. What did we call this effect earlier on in the anesthesia chapter? Of allowing the pain to occur in the periphery, but not reacting to it because the brain would simply not recognize it as being bad. It is indeed what we call dissociative as an effect, which we mustn't forget is also associated with potential hallucinogenic property of drugs like morphine. Well, this is primarily what we want of opiates like morphine and congeners, a central analgesic effect in brain and spinal cord. And as I'm looking at this analgesia, I know it comes with inhibition of neurotransmitter release, therefore there is CNS depression. At the very least, sedation could become an issue, or could become an advantage. If you're in a hospital and you're a patient in pain, feeling sleepy or being sedated is, after all, potentially not so bad. On the other hand, if you're treating moderate pain as an ambulatory patient and today you have to drive to work, you may not feel too happy with that sedation. The worst case scenario as we increase the dose, like for all CNS depressants, whether they were the ones working on GABA like benzo, barbiturates, the alcohols, whether they were the anesthetic medication, the possibility of respiratory depression. This respiratory depression is an interesting respiratory depression. Let's remember on another little diagram how respiratory centers work when it comes to physiology. Look, there are two centers, aren't they? One's in the medulla, in the brainstem, let's say, that sends PCO2, and another group that sends PO2. The centers that sense PCO2, they work in the following fashion. If PCO2 increases in the body, they tell you, breathe, so that you can blow out the actual CO2. Conversely, the centers that are in the periphery, and the aortic bodies, the carotid bodies, they sense the oxygen. And their way of functioning is when we lower oxygen in the body, then they tell you, please breathe, your oxygen is going down. You know, clinically, that's what we often refer to as the hypoxic drive. It is a minor respiratory center unless the PCO2 centers do not work. PCO2 centers are the ones in the CNS. They are the ones that have mu receptors, and mu receptors through their GI coupling will literally shut down the PCO2 centers. So what is left for the patient to breathe? What is left for the patient to breathe are the hypoxic drive centers in the periphery. Essentially telling you this very important point: do not give oxygen to a patient under the influence of an opiate unless that patient is mechanically ventilated. Because literally, by administering oxygen, this will cause the patient to decide not to breathe because oxygen centers would no longer have to stimulate the breathing system. No, rather, if there is an overdose to an opiate with respiratory depression, you cannot give oxygen, but surely you have an antidote, the opiate antagonist naloxone. Well, this is an important clinical and board question about the reversal of respiratory depression in overdoses by the drug naloxone. If we go a little bit in the periphery, opiates and their receptors are not plentiful at all in the cardiovascular system, so we would suspect minimal effects on heart tissue. But often, and for morphine in particular, through histamine release, a hypersensitivity reaction, through histamine release, there can be significant vasodilation, which is a reason to avoid it in head trauma, because then there could be increased capillary permeability and the potential of increasing intracranial pressure with a classic herniation problem. So overall, no big cardiovascular effect. Contrast, in smooth muscle of gastrointestinal, genitourinary, or biliary tract, there is tremendous pharmacology of opiates. It is complex, but overall this is the way I would think of it. Longitudinal muscle relax, circular muscle constrict under the influence of an opiate. What do we mean by this? Well, what we mean by this, imagine your GI. You remember longitudinal muscles such as Taenia coli in anatomy? Well, those would relax and stop moving. If they don't contract, there would be no peristalsis and severe constipation with an opiate. Yet at the same time, every sphincter muscle, every circular muscle goes into spasm. So this is an awfully uncomfortable constipating effect, whereby maybe there is constipation, but there's also tremendous cramping to the point of abdominal pain, colicky pain in that patient who strains to go to the bathroom. This is why, to try and avoid that muscle spasm, it is common to see the use of antimuscarinic drugs, drugs such as atropine, given in conjunction with the opiate to prevent the spasm of the GI. You could repeat the same thing in the GU tract with urinary retention in spite of urgency to void, and do so also in the biliary tract. Except here we can even make it a nice clinical story. Imagine that patient with right upper quadrant pain that radiates to the right shoulder, and of course that is excruciating while that patient is also turning yellow. I'm sure you're thinking possibly some liver problems such as gallstones. Well, it is a very painful situation whereby biliary colics, some patients even think they're having a heart attack, it's so painful. Would it be a good idea to give such a patient a morphine-like drug? Well, let's think of it. It will certainly relax the longitudinal muscles of the biliary tract, therefore decrease peristalsis and potential excretion of the stones, which are now more likely to impact the actual ducts. And on top of it, it will cause increased spasm and constriction of sphincter muscles, such as the sphincter of Oddi. So it would decrease the clearance of stones. And by increasing the actual pressure in the biliary tract, possibly through the spasm result in rupture of the gallbladder and its tract and possible peritonitis. There is no doubt it would not be safe to use a drug such as this one unless at the very least I was preventing the cramping and spasm. And of course, if I could have an anti-muscarinic opiate, I would be very happy for that matter. Now, nothing to do with GI-GU tract, but talking about circular muscle constricting, let's think about the sphincter muscle of the pupil. There is that classic telltale effect of these medication, which is to cause pinpoint pupil miosis. Now, we've even explained at the molecular level what happens there. It is the imbalance in the autonomic responses of the eye that results in miosis. The decreased norepi results in the appearance of too much acetylcholine on muscarinic receptors being unchecked by sympathetic activity, blunted through morphine administration. Well, we use that miosis primarily as a telltale sign of a patient under the influence of opiates. Morphine and many morphine-like drugs have a fairly strong cough-suppressing effect. This antitussive action is indeed independent of analgesia and respiratory depression. Understand by this, it is due to a different subtype of opiate receptor. It is not mu-mediated. Now, this opens the door for smart chemists to develop cough-suppressant medication that would be devoid of the other opiate pharmacology, namely the risk of respiratory depression and possibly the potential for abuse. Nausea and vomiting is a classic response to morphine-like compound. This stems again not from a mu receptor, but a direct stimulation of the chemoreceptor trigger zone, particularly through dopamine D2 type of receptors. This is always a little issue because pain can be a cause of nausea and vomiting, in which case a central analgesic like morphine can curtail this type of vomiting. Yet at the very same time, the drug itself can directly stimulate vomiting center and be associated with nausea as a side effect. Final point in that morphine pharmacology, the possibility of histamine release. You remember, I'm sure, how we use this histamine release as a cause of vasodilation and certainly a reason to avoid the use of that drug in head trauma. Looking at the kinetic of morphine and other morphine-like drugs, glucuronidation is the primary mode of metabolism, and this conjugation should result in excretion of the conjugate primarily through bile and kidney. Well, here is the surprise. It will probably be the only place throughout your boards where you'll talk about a glucuronide that is more potent than the actual parent drug. This is an active metabolite that is several-fold more intense than the morphine itself. You know, it gives us a little flag here when we're going to ask our laboratories in hospitals or private labs to monitor the levels of morphine in a patient. I would always recommend that you make sure that the results returned to you include not only the morphine, but also its major metabolite, morphine 6 glucuronide. Imagine the case scenario where morphine would be low, but the glucuronide would be elevated thanks to possibly a renal dysfunction in this patient. Then you could actually see life-threatening toxicity not from the parent drug, which might be within therapeutic range, but from the morphine 6 glucuronide. So always ask for both to be measured so as to be safe and avoid respiratory depression. In this table, we try and review other opiates, knowing that some of them will be similar to morphine and others will have unique characteristics. If we start with the full agonist, drugs that are like morphine, well, let's put in there at least two major drugs, meperidine and methadone. Meperidine is also an anti-muscarinic drug. As an anti-muscarinic drug, it will be associated with no meiosis. So this is the only opiate that will not result in pinpoint pupils. As an atropine-like drug, we cannot say it has minimal cardiovascular effect. To the contrary, it has the potential of causing tachycardia, including torsade rhythm. But it has the advantage of causing no spasm of GI, GU, and gallbladder. So as to these situations where patients had severe cramping of the viscera or the potential issue of biliary colic, it would make the drug meperidine quite relevant. If some of you are from foreign countries, and I'm sure many of you are, just like me, anywhere around the world, we don't call meperidine meperidine. We call meperidine pethidine. So let me give it to you here so that like this you realize what drug we're talking about. A very famous drug that is used around the world as a central analgesic. One of its trade name, for instance, is Demerol. So when I'm looking at meperidine, I need to know it well and contrast it to morphine. Besides the fact that it's the only opiate that is anti-muscarinic, its metabolism is unique too. Rather than being conjugated by glucuronidation, this is a medication that is metabolized by cytochrome P450s. P450s result in formation of normeperidine, and normeperidine has a pharmacology. It is a serotonin reuptake inhibitor. It's really an SSRI. And having too much serotonin, which we'll call in the antidepressant serotonin syndrome, can result in life-threatening seizures. So these are points to recall well for meperidine and for question and answers on board exams. For methadone, it's pretty straightforward. Who would not remember that methadone is actually used in maintenance of an opiate addict? That is its primary use because it is much slower in its kinetic than morphine, so as such is less likely to provide the addict with a rush. It does not increase very suddenly in the brain of that individual. And being slower, it has a long half-life. Its duration is literally 1 to 3 days. As such, you are less likely to withdraw from drug with long duration of action since they tend to taper themselves. And that tapering prevents the occurrence of withdrawal syndrome. There is one major issue though. Drugs that have long half-lives take a long time to reach steady state. And if your patient is still a drug addict out there on the street, then this patient unfortunately will possibly overdose on the combination of heroin, morphine, drugs of abuse, and the methadone given in the methadone clinic. You know, there's a classic peak of mortality 2 to 3 weeks after the starting of methadone, which would just about result in when methadone is at steady state. If your patient is used to a certain dose of heroin, they might use that dose thinking that never caused me any problem, and now unfortunately go into life-threatening respiratory depression. So something to monitor, of course, if some of you will go into this arena of medicine. Codeine has now been placed by some of my colleagues in the full agonist section. Codeine is really a weak agonist to the extent that actually it should really belong to partial agonists. Codeine as a weak agonist is primarily used as a cough suppressant and is used as an analgesic, but not a strong analgesic. As a matter of fact, it's generally used in combination with NSAIDs. The point about codeine, I think, that wants to be made here is that it truthfully is a morphine-like drug. For instance, if you wanted to give it to someone who has chronic severe coughing, you would have to give it under a prescription. By no means would you ever find codeine over the counter in this country. It is a drug that is associated with abuse, and it is a drug in overdose that can cause significant CNS depression. But it's many-fold weaker than the full agonist morphine. On this same slide, you're looking at the partial agonist buprenorphine. Buprenorphine is, again, weakly agonist on mu receptors to the extent that in presence of a full agonist it could precipitate withdrawal. The relevance of buprenorphine is that it is available IV in emergency room to manage mild to moderate, even severe pain. what would happen if your patient was actually a heroin addict coming in the emergency room? Would buprenorphine kick the heroin off and give a nice agonist effect? Or would buprenorphine behave as a blocker? Well, you know the answer. Buprenorphine, the partial agonist, would behave as an antagonist in front of a full agonist. This is why it would precipitate withdrawal and certainly not be associated with analgesia, but rather with causing the patient to become extremely agitated, and even worse pain would be felt by this individual. We'll talk about withdrawal a little later, but this is classically the relevance of buprenorphine as far as a board question. Now you may wonder, why use partial agonist? Well, let's not forget that with a ceiling effect, a partial agonist is 1, safer, if not 2, less efficacious. As a safer drug, it is also potentially a drug that would be less likely abused. Other partial agonist drugs have been placed in a group of their own, the mixed agonists-antagonists. The fact that there's that duality of agonist-antagonist tells you clearly they are partial agonists. But also what it tells you with the word mixed is that they don't only work on mu, they also work on other subtype of opiate receptors. This is your chance for the board with drugs such as nalbuphine and pentazocine to have an ounce of information about kappa receptors and what they do for a living. Kappa receptors and their stimulation is still GI coupled and still affords significant analgesia, particularly spinal analgesia through decreased substance free release. But kappa stimulation has a major difference from mu stimulation. You see, when you tickle kappa receptor, you do not get euphoria and good sensations. You get dysphoria. Dysphoria meaning the patient feels really lousy. The idea of giving a drug that is an analgesic that makes you feel lousy is again to try and avoid the abuse potential of these opiates. Unfortunately, if you were planning on using it in an opiate addict, because it's a partial agonist, it will behave as a blocker of mu responses, so making it very impractical, being that theoretically these would be the drugs to use in a heroin user that would actually precipitate withdrawal. A little bit like buprenorphine, really. As far as the last box in this table, let's talk a little bit about the antagonists. Naloxone is the antagonist that is only used IV to reverse respiratory depression. So what's the deal with naltrexone? Naltrexone is not to be confused with naloxone. This is a drug that is given orally and has nothing to do with reversal of toxicity. It is used to decrease the craving for alcohol and is also used in the management of opiate addicts. The fact that it's used to decrease craving in alcohol has been a board point, particularly with behavioral sciences. Methyl naltrexone is an analog of this opiate antagonist, which is used primarily to reverse the severe constipation that morphine-like drug can induce in patients. This constipation is really a limiting side effect of those medications, particularly when we try and manage end-stage cancers. These are patients who develop such severe constipation that they may even end up with intestinal obstruction because of the analgesic they receive through infusion pumps. So in that situation, it is quite neat to use an opiate antagonist, which has the point through its methylation of primarily staying in the gut, and as such, not opposing all the systemic effect of the opiate inside the patient's body, so that really it only will work at reversing the constipation. Side effects of all the opiates that are agonists in acute toxicity, a classic triad: the pinpoint pupil, respiratory depression, and coma. It is the fact that a patient is comatose while having pinpoint pupil that is so striking. We expect dilated pupils in people who have respiratory depression and coma. Not so here, except for one drug. Do you remember what the name of the drug is that will not cause pinpoint pupil? Yes, it is meperidine. And why was that? Because meperidine is an anti-muscarinic medication. In all cases, management of acute toxicity will be primarily supportive, and the use of IV naloxone to reverse the respiratory depression is always indicated. Finally, for those morphine-like drugs, some words on the abuse liability of opioid analgesics. These days, there is a major issue in the Western world with overuse of opiates for management of pain, particularly drugs such as you might have heard of on media or read about in news, like hydrocodone, like oxycodone. Actually, you recognize in codone a similar word as codeine. And these compounds are very classically used to manage in ambulatory patient pain condition. Problem is that they do have a fairly strong abuse liability, and there is a very thin line between the therapeutic use of the opiate to kill the pain and the actual abuse of an opiate because of its euphoria and addictive liability. That line is unfortunately often crossed by our patients and causes an issue of who is liable for the actual abuse when it occurs under prescription drugs. Well, I'll let you think about this a little bit, but it is known that they are associated with significant tolerance, resulting then in the need of increasing the dosages in order to reach similar type of pharmacology. Between you and I, there is one thing we have a hard time becoming tolerant to. Unfortunately, it's death. So invariably, drug addicts tend to eventually overdose, and overdose to an opiate in a back alley or at home will very much result in a life-threatening situation thanks to the respiratory depression. Well, this tolerance, interestingly, occurs to all effects except meiosis, the pinpoint pupil, and the constipation. If I knew why, I would have published it. Certainly, there is very little understanding as to why certain effects exhibit tolerance and others don't. Certainly also, as medical practitioners, we would be very happy that there is no tolerance to meiosis, since we use that as a feature to recognize the opiate addict. The fact that we don't lose the constipating effect, on the other hand, is not very nice. We would have loved to see that side effect wane away upon chronic usage of opiates for pain management. There is a key word in that tolerance, and this key word is the word pharmacodynamic. See this? Pharmacodynamic means it's an effect at the level of receptors and signal transduction. Here's the point here. The boards has actually tested this pretty isolated in a way. Normally, we expect the following. Let me take another sheet so I can show you a little better. Let's imagine this is a cell with receptors. I'm just going to call it REC for receptor. What tends to happen to receptor if I overstimulate them? I'm sure you're thinking when receptors are overstimulated, they're going to tend to desensitize, in other words, not respond as well, or downregulate. Downregulation meaning they change in number. Whatever the case might be, what you would imagine is that this receptor that used to cause a response that was this big, now after time is going to give you a response that is that big. So that there's only one way of getting back to big responses. We're going to need to take more and more and more and more of the drug to stimulate the receptors, constantly trying to get back to the big response. Well, if that's the classic, and we're all familiar with this, similarly, blockers will tend to cause hypersensitization and upregulation of receptors. There must be a reason why your board is asking about the opiate and its mode of tolerance. And here is why. In opiates, it is not the receptors themselves that change. The mu receptor is not going to desensitize or downregulate. Rather, it is downstream from the receptor, the signal transduction, that will be altered. What was the normal signal transduction of mu receptors? Normal mu signal transduction is GI mediated, a decrease cyclic AMP. Well, here's why your board is so excited. In the tolerance, what is seen is actually the cells managing to raise their cyclic AMP levels by using other type of G protein coupled receptors on the same cell. So it's an adaptation of the actual neuron that is such that it undoes the effect of a GI coupling from mu receptor. Well, that's what we call pharmacodynamic tolerance, an effect that is actually at the level of responses of the chemical. This is, by the way, to oppose it to what we would call pharmacokinetic tolerance. In pharmacokinetic tolerance, you would have such issues as inducing P450s in order to metabolize the chemical faster. You would have issues of changes in clearance or absorption and so forth. If it's not kinetic, it's dynamic, and dynamic is at the receptor level normally, except for the opiate, it's at the level of cyclic AMP. Let's talk a little bit about the dependence to an opiate. Just like dependence to other drugs of abuse, we describe physical and psychological dependence, therefore an abstinence syndrome and also craving on cessation of the drug. The withdrawal is quite classic once again. Let's imagine this. What was one big neurotransmitter that had been suppressed chronically? Let me go back to another white sheet here. You remember that the chronic opiate actually worked in part at decreasing norepinephrine synthesis and release. So because of the chronic opiate, what do you think has happened to alpha-1, beta-1 receptors, a little bit based on what we were saying on the previous slide? I'm sure you're answering, because of decreased norepi, these alpha-1s are going to tend to multiply, these beta-1s are going to tend to multiply, trying desperately to give a response even though norepinephrine is low. So now, in blue, let's remove the opiate. Let's remove that sudden inhibition of norepinephrine release. You won't have time at the time of cessation to re-regulate the alpha and beta receptors back to their original level, so that now you have norepinephrine working on all these excess receptors, causing a massive sympathetic autonomic nervous system response. So a big part of the withdrawal syndrome and its symptomology is going to be associated with too much sympathetic activity in this patient. If this is so, you should remember a drug that we saw in the antihypertensive section, the drug clonidine. What do you think clonidine will achieve during withdrawal? Well, first, do you remember how clonidine works? It works as an alpha-2 agonist. An alpha-2 agonist decreases that norepinephrine. So in effect, by giving clonidine to the patient, I am effectively replacing the molecular effect of an opiate with that of clonidine, the effect of a drug of abuse with a drug that does not get associated with abuse but will cancel the sympathetic flare-up in that patient. This is why we always will say that if we use clonidine, we will alleviate or we will temper down the withdrawal syndromes. Let's talk about the symptoms. Well, first thing that happens with sympathetic activity is to get agitated. And as you get agitated, I don't know if you've noticed, maybe right now actually you are getting agitated in front of the screen. One characteristic is people starting to get fidgety and start yawning. Yawning is actually one of the first signs that the patient is in the process of withdrawing from an opiate. Then will come increased secretion, lacrimation, the nose, salivation. And I'm sure you're looking at this and you're like, hold on, that doesn't sound very sympathetic, that sounds parasympathetic. Well, not so quick. If you were becoming emotional right now in front of your screen, by the way, I wouldn't even see you, so don't worry. The fact is, wouldn't you potentially burst in tears when you're emotional? This is exactly what's happening to this patient. They're starting to lacrimate. Wouldn't you start sniffling when you start crying and be in the need of tissue? And as far as salivation, when we are stressed, when we become emotional, the type of saliva is quite relevantly more profuse but also much thicker. This is when it feels very pasty in your mouth. So believe me, these are responses that are definitely sympathetic here. These are not salivation in order to digest, such as we would with the parasympathetic. So having said this, let's culminate that now with anxiety, sweating, with a patient who will start feeling very scared, basically suffering flight, fright, or fight. All of these symptoms can be easily managed in a way with the drug clonidine. What else will happen? Let's not forget that opiates cause severe constipation, urinary retention. So what would you expect at the level of the gut? Well, symptoms such as diarrhea, incontinence, not the best thing to have, no doubt. And then because that patient on morphine was heavily under an analgesic effect, the sudden removal of a central analgesic will result in CNS originating pain. That is literally the brain of this individual is now inventing a pain that does not exist. Imagine this, centrally mediated pain. There is only one approach for us clinically. Place that patient back under the influence of a central analgesic. But rather than using the very fast-acting morphine, heroin-like drug, let's put these patients on the slow-acting methadone. And methadone will simply supplant the use of an opiate from the street with one from the clinics. The bottom of this slide is unrelated to abuse liability. The bottom of this slide gives us two other opiate medication which have unique uses. We need to know well the drug loperamide. Loperamide is marketed as a trade name over the counter as Imodium. And loperamide is available also in many generics that are called, of course, loperamide. This is a drug that is used to treat diarrhea. It's a strong constipating type of agent. I like to refer to it as a concrete maker. And as you look at loperamide, an important point about it is the fact that it is not absorbed and does not share any of the other opiate pharmacology. So it's an analog that is purely used for its constipating effect. By the same token, the drug dextromethorphan is also used over the counter, but purely as a cough suppressant. Now recall that the antitussive action of opiate is not mediated by the same mu receptor than the one associated with addictive liability, respiratory depression, and analgesia. Dextromethorphan, nonetheless, is suddenly causing some big worries because of an abuse liability. But you see, it is unrelated to its pharmacology as an opiate drug. Dextromethorphan is also very similar to the drug ketamine. So it has been used, particularly by teenagers who can have easy access to it going to regular stores, as a drug to result in hallucinations. And those hallucinations occur only with very high dose of cold medication and can become extremely toxic. Dextromethorphan can result in tremendous potential for status epilepticus at very high doses. So some of you will no doubt encounter some people who have quote-unquote gone on dextro. Actually, a famous hip-hop song familiarized or popularized going on dextro from a group in Houston a few years back, and caused really up-to-date now a number of young people to get severely intoxicated with compounds like coricidin, for instance, that you find over the counter. Anyways, this will end our opiate analgesic chapter.